reasons. I've been coming back to Hamilton for 40 years because I have family here, and every time I come back from Hamilton, from Toronto to Hamilton, a major reason was to spend time with my brother-in-law, Lou Greenspan. And I'd like to actually dedicate my talk to Professor Lou Greenspan. As it said in his obit, Louis died as he lived, with wisdom, great dignity, profound humor, and a deep love of life. And I dedicate my talk to Louis. Among my various degrees, I have a degree in nutritional sciences, and I spent close to 5 years doing my PhD in nutrition. And you are fortunate today because I'm going to give you, in one slide, all I learned in 5 years. And in fact, the three things I have on the slide are by far the most important things about nutritional science. And if in fact, if you know those three things, then one can remain nutritionally healthy. And those three issues that are directly related to what I'm going to talk about today are variety, quality, and moderation. So that if one eats a variety of foods, it's unlikely that any one nutrient will be missing from the diet. If you're not eating a good variety of foods, then the quality of food that you eat becomes particularly important. And then, for reasons that we're all aware of, moderation is very important, at least for adults like ourselves. So really, although it took me 5 years to realize, these are the three keys to maintaining nutritional health: variety, quality, and moderation. As I say, variety is the key to the prevention of nutrient deficiencies, and when variety is limited, nutritional deficiencies will appear, unless the food eaten is a very high quality or unless it's a fortified food. And this is a picture, of course, of a baby who's breastfeeding. And one might ask the question, if I've just said that variety is the key to the prevention of nutritional deficiencies, how do we get away with recommending, and this is a recommendation from the World Health Organization, from the Canadian Pediatric Society, we recommend that babies in the first 6 months of life eat one food, which of course is not variety. And that one food, of course, is human breast milk. The reason we can get away with a lack of variety during this extremely important first 6 months of life is because human milk is of the highest nutritional quality. If you look at infants between 6 and 12 months of age, which is a very rapid growth period, the number of different foods they eat in Canada is 6 or 7 different foods, which is still relatively limited. And I would say that at that age, because infants are growing so quickly, they are at risk for nutritional deficiencies. Between 1 and 12 years of age, the number of different foods, this is not food groups, but different foods they eat. So for example, an apple is a different food than an orange, and toast is a different food from jam. So between 1 and 12 years of age, it's estimated that children eat 12 to 15 different foods. And that's why between 1 and 12 years of age, at least in a Canadian context, we see very few nutritional deficiencies. And teenagers who at least eat 15 to 20 different foods per day, or even more, it is very rare to find nutritional deficiencies. But as you can see from this first slide, the first year of life, in fact the first 5 years of life, are particularly important. And if in fact you're living in an environment where the variety of food is very limited, as it is in developing countries around the world, you will not be surprised to hear that deficiencies of very important nutrients for growing children become important. One of the ways in Canada that we've got around this lack of variety is related to the fact that at the Hospital for Sick Children in the 1930s, they came up with a product which is known as Pavlum. Believe it or not, we are still at Sick Kids using the royalties of Pavlum to support the research institute at the Hospital for Sick Children 70 years after it was invented. One of the most important things about the invention of Pavlum is it was the very first fortified cereal. And you might say, why do we need fortified cereals? In the 1930s, the diets of Canadian children were probably pretty similar to the diets of children today living in developing countries. So the development of Pavlum at Sick Kids was an extremely important discovery. And you can see on the right-hand side of the slide, we have package of Gerber cereal, and this is actually an ad from the 1940s, and the important thing here is that this Gerber cereal was fortified with iron. So iron is one of those nutrients that I'm going to be talking to you a lot about, but you only get an iron in your diet usually from meat, fish, and poultry. And in the first 2 years of life, children, even when they can afford it, don't eat very much meat, fish, and poultry. And it was realized, again, 50 or 60 years ago, that the way to maintain the health of Canadian infants and young children was to fortify their baby foods. And the concept of fortification as a nutritionist is very, very important. You won't think much about fortification, but you eat foods that are fortified, and they actually help you maintain your nutritional health. So, for example, our wheat flour in Canada is fortified with folic acid. Folic acid is a nutrient that has a lot to do with the development of the nervous system in young infants. And if mothers are deficient in folic acid, they're at risk of giving birth to children with spina bifida, or children actually without a brain. 20 years ago in Canada, exactly 20 years ago in November of 1998, we started adding folic acid to our wheat flour, which is put into bread, it's put into pasta, it's put into all the foods that we eat. Before 1998, the incidence of neural tube defects in spina bifida in Canada was around 1,000 infants per year. And since that time, with this one small gesture of adding folic acid to our wheat flour, that number has decreased by 50%. I was reading this week in The Guardian in England. England does not fortify their wheat flour with folic acid. And the estimate is, over the next 10 years, if they start fortifying their wheat flour, they will save actually 10,000 lives. This is the most simple intervention, nutritional intervention. It costs 50 cents per metric ton of wheat flour. So why the Brits haven't done it when we started and America started 20 years ago is totally beyond me, but they, I think, are starting now. This is a picture of a baby that I took actually in Ghana. It doesn't show up that well, but it's a baby on a mother's back. And I show this picture just to remind you to say that in places like Ghana, which is a country in West Africa, babies breastfeed for the first 6 months. Pretty good at that. The World Health Organization recommends it, and for the first 6 months, they breastfeed. But after 6 months, in order to maintain the nutritional health, they have to start eating other foods. And these other foods are generally foods that are available in their neighborhoods. So in West Africa, the most common cereal that's grown is maize, or corn. So the parents would actually buy maize or corn at the market, they would pound it into a cereal, and they would feed their babies these cereals. These are great foods to the infants. Unfortunately, they're non-fortified foods. And as I'm going to tell you over the next few minutes, one of the consequences of babies in the developing world, and we're talking about tens of millions of babies eating good foods, but non-fortified foods, is the increased risk of important nutritional deficiencies. And I'm going to give you 3 examples here. So iodine deficiency causes what's called a goiter, which is a big lump on their neck. And in young children, iodine deficiency can cause severe mental retardation. Many years ago, we found a way to fortify food around the world. And you can see on the slide, we actually fortify salt. And if you think about it, if you read the package of salt that you use iodized salt because it's regulated in Canada and many countries around the world, that the way that we get our iodine is through salt. The good thing about salt, it's a perfect vehicle to fortify because people use salt in the cities, in the countryside. Rich people use it, poor people use it. So it's a perfect food to fortify. And as a result of fortification, iodine deficiency is fairly uncommon in the world today. A great example of the success of fortification. The second is vitamin A deficiency. Again, not something we think about, but in the developing world, the major cause of blindness is due to vitamin A deficiency. And the way we're trying to solve that problem is through a combination of what's called dietary diversification. We tell parents, don't just feed your child the cereal grains, but try and give them some meat, fish, and poultry. In the developing world, it doesn't work very well. It works well here. Fortification works quite well, and for vitamin A, you can fortify oils. Everyone uses cooking oils everywhere in the world, and it's easy to fortify cooking oils with vitamin A. So the fortification of cooking oils has gone a long way to decrease the number of children with vitamin A deficiency and blindness. And finally, there is supplementation. You can actually give a pill to infants in the first year of life that has a large amount of vitamin A that solves this problem. And you don't know this, because I didn't know this, but Canada is the major supplier of vitamin A capsules around the world. Canada distributes over 1 billion capsules per year. And in fact, we use our tax money to pay for this, but it's a good use of our tax money. The one nutrient that we haven't done a particularly good job on is in fact iron. So once again, just to remind you, you find iron in meat, fish, and poultry, and infants and young children around the world don't eat much meat, fish, and poultry, primarily because it's too expensive. On the slide, you're going to see a number of graphs, and the one in the middle is India, and what this is showing is that between 1990 and the year 2000, the number of children with iron deficiency anemia in this massive country is around 70 or 80% of the population. This is absolutely incredible. And you can see that over a period of 10 years between 1990 and the year 2000, despite the fact that there were recommendations to ensure that children received enough iron, that in fact the programs that were available between 1990 and 2000 were universally unsuccessful. So you're left with children around the world, and India is a great example of that, with iron deficiency anemia. And I'm going to tell you in a moment why that's important. So in 1990, there was a World Summit for Children, and it has set a goal for the international health community to reduce iron deficiency anemia by 1/3 by the year 2000. It was absolutely not achieved. In 2004, there was something called the Millennium Development Goals set by the United Nations and the World Bank, and their goal was to reduce the rates of anemia by 1/3 by the year 2015. And once again, we're starting to approach that, but have not yet reached that. This is just another slide to show you that on the axis here we have the number of people in the billions, and you can see that in 1990, the number of people with iron deficiency and anemia was around 1.5 billion people around the world. And you can see that 10 years later, in around 2000, the number with anemia had gone up from about 1.5 billion to an even higher number. So again, just to make the point that despite the fact that the United Nations, UNICEF, and the other agencies who are responsible for preventing and treating anemia and iron deficiency, generally, they were totally unsuccessful. So a question that you should be asking yourself, that of course I ask myself, is what is the impact of iron deficiency anemia on actual outcomes? Why should we, and I say we, I'm talking about the public health community, why should we be worried? Well, in fact, there are significant outcomes. In adults and children who have severe iron deficiency, there are high risk for stroke and death from severe anemia. There is morbidity from even from moderate and mild anemia, and I'm going to show you that. So in young children, they show altered behavior and cognition, such as increased fearfulness, wariness, irritability, unhappiness, and lower IQ scores. It used to be that if you asked an old-time pediatrician, could you tell whether your child who's entered your office has anemia or not, they would say, I could tell within 2 minutes of the child coming into the office. They wouldn't explore my office, they wouldn't leave their mother's side. These are children who had severe iron deficiency. And he said, within 3 weeks or 4 weeks, when they came back to my office, these children were totally different. These children demonstrate altered motor development, that is physical development, such as decreased exploration of their environment, decreased willingness to leave a caregiver's side, and increasing fatigue. And iron deficiency is the most prevalent form of malnutrition among infants and children in the world today. And that today includes 2018. This is a research project which asks the question, what happens in terms of the intellectual development of children who have iron deficiency anemia versus those who don't? So as you might be able to see on this scale, children with iron deficiency scored markedly lower in performance IQ, in fine motor, in visual matching, in quantitative concepts, that is arithmetic. They scored lower in picture vocabulary and in visual motor integration. So without a doubt, the conclusion by the academic community was, not only is this the most prevalent form of malnutrition in children 20 years ago and 10 years ago, but it has significant both physical and mental implications for a growing child, particularly in the first 2 to 5 years of life, because as you may or may not know, brain growth is faster between 6 months of age and 2 years of age than any other years of the child's life. And in fact, sometimes you look at children who are 2 years of age and say, boy, they look like they have a big head. It's because brain growth, again, is rapid between that 6-month and 2-year period. And the size of the child's brain at 2 years, the size of the child's head at 2 years, is really not much different from the adult head size. So this early period in development of a child is particularly important, and iron plays a huge role. So what are the risk factors for, I say, micronutrient deficiencies? Micronutrients are nutrients like iron and calcium and all the minerals and vitamins. And here are the risk factors. They are diet. If your diet isn't good, you're likely to be at higher risk. Age, younger children are at higher risk for the reasons I talked about. The variety of foods they eat is low in young children. In some countries around the world, season is important. In Africa, they have what's called the hungry season and the non-hungry season. The hungry season is defined as the time after the crops have been picked and stored, but before the next crops are grown, when they're running out of stores, is called the hungry season. So that certainly is a risk factor. Income is clearly a risk factor. Emergencies, if you're living in a place where there's a war going on, of course this would affect your ability to obtain food. And certainly arid rural areas or marginal food production would affect the risk of micronutrient deficiencies. But the most important risk, by far, is poverty. When you're living in poverty, it is very difficult to meet the nutrient needs of a population. And that is true anywhere in the world, including Canada. Just to give you an idea of poverty, this is a picture that I take along the road to the health facility that we use in Ghana. This is actually a health facility. You can see some children standing in front. And just to contrast that, this is the place that I work. This is the Hospital for Children, which was built actually in 1993, but you can see this is a modern health facility that clearly does not reflect poverty. So if you're living in Canada, you are less likely to be affected by poverty than if you're living in a country like Ghana, which is one of the better off countries in West Africa. So, really important choices. What are the public health choices for the prevention of mineral and vitamin deficiencies? And in fact, there are 5 choices. How are we going to solve this? So the first is increased variety of high quality foods. This will absolutely work if the parents can afford to buy high quality foods. But in the developing world, in low and middle income countries, this is absolutely unsuccessful because the most expensive foods are meat, fish, and poultry. So this doesn't work. Commercial targeted food fortification. By that I mean the pablums or the cereals that we feed our infants. These are cereals that are fortified in the factory. And again, there are 2 reasons why parents in the developing world may not use them. One is they're expensive. And 2 is culturally, parents simply don't buy baby foods. They make them from local commodities. I was giving a lecture like this in India, not the same lecture, but a lecture like this. And I showed this slide saying that in the developing world, and India is still, in parts of India, a developing country, commercial targeted foods are not used because they're too expensive. And after the lecture, a person came up to me who was a physician, and he said, you know, I'm rich. And he said, my family has no problem buying whatever we want. But my parents live with us, and they help us make decisions about what we feed our children. We definitely feed our children with homemade food, not because we can't afford it, but it's the culturally appropriate thing to do. The challenge of homemade foods is that if they're made from grains or cereals, they need fortification, because even in Canada, we use fortification. In Canada, the rates of anemia are around 2 or 3%. In India, the rates of anemia are around 60 or 70%. So even if you can afford it, in many cultures, they simply don't use commercial baby foods. What's the third level of prevention? It is called general fortification. I gave you the example of fortifying wheat flour with folic acid. You can also fortify with wheat flour with iron, and in fact, we do that in Canada. But the level of fortification is targeted to those who eat the most food, which are adult males, and adult males actually don't need very much iron. So although countries can have general fortification, the level of fortification and the amount of food that's eaten by a young infant is simply too low. So these first three public health choices simply don't work. Then we're left with two that have the potential to work. One is individual supplements, and the other is home fortification. So, this is just a slide to make the point that this slide shows iron fortification from cereals. This slide shows that most infants in Canada get most of their iron in the first 2 years of life from that big brown bar, which are fortified infant cereals. General fortification, I said. We're left with two others. One is individual supplements, which we're all familiar with because many of us probably take individual mineral or vitamin supplements, and then I'll talk about home fortification. So, one of the interesting things about individual supplements, here we're talking about iron supplements for young infants. So just remember that an infant under the age of 2 really can't swallow a pill or a tablet. They have to use liquids or syrups. And the iron syrup doesn't work very well. And in fact, when I started working in this area, what I found is that there were no universally successful large-scale treatment programs, despite the fact that iron syrups have been available for literally 100 years. And there were no countrywide successful prevention programs for infants and young children. And you can see an example of the type of syrup and dropper that would be used to provide iron to an infant. So the question would be, why are these programs so unsuccessful? And the issues are all related very specifically to issues around compliance. So, why is compliance so bad? And there are actually 5 reasons. And these are, they may sound like simple reasons, but they have really an important effect, and so important that none of these programs are successful. One is, iron has a very strong metallic taste. You might be able to give it to an infant for a week or 2 weeks, but to give it to the infant for 6 months, which is how long they might need it, or a year, is virtually, well, I'm not going to say impossible, but very, very challenging. The iron drops through syrup actually stain a baby's teeth a brown color. You can get the staining off if you brush the teeth very hard, but as you know, many of you of course are parents, you know, or grandparents, you know that you don't want your children's teeth to have a brown stain. Many of the women that we deal with in the developing world are illiterate, and the measurements through the dropper are actually hard to measure. They're in metric units, and many don't understand metric units, so hard to measure. There is a potential for overdose when you're using a liquid supplement. And finally, a medical model that is giving this once or twice or 3 times a day for a 6-month period is very hard to sustain. So for those very practical reasons, despite the fact that there have been iron drops of syrup around for 100 years, they don't work. The start of the story of micronutrient powders or sprinkles. As a pediatric nutritionist, I had developed my reputation as a researcher, researching babies who were born prematurely and looking at their mineral and vitamin needs. And I was surprised back in the mid to late 1990s to get a call from UNICEF. UNICEF have their headquarters in New York, and their distribution headquarters is in Copenhagen. In fact, the Danish government gives them a huge building on the coast to distribute everything from cars to computers and emergencies to food to everything. It's this immense building in Copenhagen. So they asked if I would come to Copenhagen to give them advice on the issue of iron deficiency anemia. And they really had 2 major problems, 2 questions there were actually 3 consultants, myself and 2 others. They said, is this really a problem? Is it an important problem? And what can we do to solve the problem? So I went to UNICEF, and all consultants said the same thing. Yes, we reviewed the literature. It is an important problem. It has a significant effect on the health of babies. The third one, though, what should we do about it? We all shook our heads and said, not a clue. Really don't know how to deal with this. And the people from UNICEF said, you can't tell us that you don't know how to deal with this. We said, yes, we can. Because we actually don't know what to do with it. We said in North America we know how to deal with it because we use fortified baby foods that are purchased in the shop. But of course, in most of the world, that doesn't work. So I went back to Toronto, and over the summertime I thought about that. And again, I thought about the concept of fortification and came up with the idea that why couldn't we fortify the baby foods in the home? And we called this concept home fortification. We thought we would have to use both an alternate source of iron and an acceptable delivery system. So one of the things about iron that I mentioned is it has a very strong taste, and it's something which scientists would call fairly strongly oxidizing. If you mix iron with other foods, it can actually change the taste or the color of the other foods. So I thought, why couldn't we deliver the iron in a small package? We're all familiar with sugar packets or artificial sweetener packages, and it's a great way to provide an exact amount of something. So why couldn't we put a powdered form of iron into a little package? And then we thought about the issue is if you add it to food and it changes the color or the taste of the food, the parents won't use it. So we thought about the concept of something called microencapsulation. Microencapsulation simply means that you take a molecule of something and you surround it with an inert substance that masks the taste. And in the pharmaceutical industry, they use taste masking for a wide variety of foods. For example, Tylenol. You don't know it, but Tylenol is taste masked because if it wasn't taste masked, it would have a terrible taste. So the concept of taste masking in pharmaceuticals is well known, not very well known in the nutrition field. But we said, why couldn't we microencapsulate the iron so that we mask the taste, and when it interacts with the food, it doesn't change the taste or color of the food. And then we said for a delivery system, why couldn't we use small sachets? The issues that were considered for the development of home fortification included all of the following. All infants ingest complementary or baby foods, and it's a great vehicle for fortification. So again, all babies eat baby foods. They all should breastfeed, but they all definitely eat baby foods when breast milk is inadequate or not absolutely adequate. And it doesn't matter if you're a rich or poor family. If you're living in a city or rural areas, all babies are fed baby foods, or what we call complementary foods. Therefore, it's a good vehicle to fortify. The form of iron is very important. It has to be a form that's absorbed by the baby. The iron should not change the taste or color of the food into which it's added. We must consider safety, that is, avoid too much, because too much iron actually can be toxic, but provide just enough. And it had to be inexpensive, because again, we're talking about families who might live on $1 or $2 a day. So if we said to them, you have to pay $1 for this, it would be absolutely impossible. So it had to be inexpensive. We came up with this delivery concept. Easy to use, highly acceptable among children and families aged 6 to 24 months. It had to be food-based rather than a medicinal approach. Did not require literacy to use it, because you can simply tell a mother to open the package and to sprinkle it on to whatever food they're using in their baby. They didn't have to measure anything. Does not conflict with breastfeeding practices, very important. This is used in baby foods after the baby has finished the exclusive breastfeeding period. It's in fact used to support the timely introduction of baby foods. Can be used for other ages throughout the cycle. These are lightweight, easy to store and transport as compared to a liquid, which is mainly water, and they're inexpensive and low-tech to manufacture. So this was the theory that we came up with before we went back to speak to UNICEF. And this is sort of what it looks like. Again, this is an after rather than before picture, but you can see this mother has a package or a little sachet, and she's adding it to her infants. Not so baby food, but infant food of perhaps a 1.5 or 2-year-old. So I went back to UNICEF and I said, you challenged us to come up with a solution, so here is the idea that I have. And I told them exactly what I just told you. We could put the iron in a powder form, we could microencapsulate it, we could put it in a little package, we could feed it to parents, it wouldn't encourage breastfeeding, and the most important thing is we're not telling them to change the type of food that they feed. If these are Indian parents who've been feeding rice and lentils to their babies for 3,000 years, if I went up and said to them, don't use rice and lentils anymore, you have to use something else, you know what they would do. Of course, they wouldn't follow that advice. So this was important. We could tell the parents to continue to use whatever food they're using to feed their child. So UNICEF said, this sounds like a fabulous idea. Here are the 4 things you have to do to get us to take this and distribute it around the world. They said, you have to show proof of efficacy, meaning you have to show that it works. Because again, remember, we were using microencapsulated iron in a powdered form, a new form of iron. Second, you have to show that it's acceptable to parents. Will caregivers use it? The third, and they said this may be the most important thing for you, is you have to find someone who's going to make it at large volume and low cost of production. Large volume, so let's say there are 10 million children in the world. There's actually many more than that. 10 million children in the world who need, I'm going to say, 100 sachets per year. If you multiply 10 million by 100, it is a huge number. We're talking in the hundreds of millions. So they said, you've got to find someone who's going to make this large volume at a very low cost. And then finally, they said you have to come up with some successful models of distribution. So with this challenge, and having to work at the hospital for sick children, where I was called a clinician scientist, I spent 70% of my time as a researcher, and 30% of my time as a clinician and as an educator. I was able to take these challenges, and for the next actually 7 or 8 years, follow these challenges to come up with the answers to these questions. And I'm going to very briefly tell you how I spent the 7 or 8 years meeting these 4 challenges. So the first challenge was, there was no product. There was no commercial product. In fact, no one made the product. So the first thing we had to do, in order to do our research, we actually had a product. So for anyone who's been to a big hospital, you know that big hospitals have big cafeterias, and big cafeterias often have big kitchens. St. Kitts has had a big kitchen for as long as it's been in existence. But the kitchens of today are not like the kitchens in the past. The kitchens today, they actually bring things in that are heated and they cool them down, or bring cold things in and warm them up. But our hospital kitchen actually doesn't make very many things, except maybe they heat up pizzas these days. But in our hospital kitchen, I found out, were all these incredible mixing machines that they hadn't used for many, many years. These were huge Hobart mixing machines. Once we realized that we were going to give powdered iron to the child, we realized that it really didn't cost very much more to give powdered other minerals and vitamins in the same little sachet. So this is a picture of me from a long time ago, mixing the first batch of micronutrient powders or sprinkles in the hospital kitchen. What happened actually is the hospital found out that we actually were using the kitchen, and they said for liability purposes we couldn't make it in the kitchen anymore. So we had to have a small company outside Toronto making it for us, but this was a true first production. So just to give you an idea, the sachets look like these sachets. This is not what the original sachets look like. These are the ones later on. And again, the concept is really simple. You open the sachet, you put it in whatever food is being fed to an infant, and you mix it up. And the cost per sachet, I'll talk about this a bit more later, is around 1.5 cents per sachet. So pretty inexpensive. So I'm going to say more about the cost per child per year is about the equivalent of a cup of coffee. Wow. And again, I apologize for the complexity of this, but it has multiple minerals and vitamins. Originally we started with 5 minerals that are essential to babies: iron, zinc, folic acid, vitamin A, and vitamin C. Later on, UNICEF said there are actually 17 minerals and vitamins that are essential. Why don't you put them all in the package? So the later packages had the multi-micronutrient formulation. And this is what the packages look like. And again, the question that UNICEF asked is, do they actually work and will people actually use them? So I'm going to show you a couple of slides. And these are research projects that we did around the world. This is the first study we did, one of the first studies we did in Ghana. And it simply asked the question, if you encapsulate iron and you add it to food, does it still get absorbed into the baby's body? And from the bar on your left-hand side, what this shows is that 8.3% of the iron is absorbed into the infant, which is actually pretty good because when we eat iron, about between 5 and 10% is absorbed. So the fact that we could demonstrate in children with iron deficiency anemia, that's what the IDA stands for, that the iron was well absorbed, was a great start, because then at least we could say, we know it's absorbed, what's the next research step? And this was the next research step. So the next step was, on the bottom line of this graph, you can see 3 different iron doses. One was 12.5 milligrams, the other was 20 milligrams, and the third one was 30 milligrams. And our goal was to give the lowest effective dose. And again, I'm not going to spend too much on these slides, but at the beginning of this study, the hemoglobin, which is a measure of anemia on the infants, was low, around 90 grams per liter. And at the end of the study, the hemoglobin had gone up above 100, which was great, with all 3 doses. So we concluded from this that we should use the lowest, most effective, least expensive dose, which was the 12.5 milligram dose. And we're using that dose today. So that was the second question. Does it get absorbed? What dose should we use? And one of the third questions we asked was, well, actually, this is interesting. So when we did these studies with parents around the world, and we did these studies around the world, we always did focus groups around this. We said, what did you like about it? What didn't you like about it? Did your babies cry? Were they willing to take it? And most of the time, mothers would look at us with this incredulous look and said, my baby did not know they were getting it. So why are you asking this ridiculous question? We would say, did you have any trouble using it? And they'd say, no, we just opened the package, we mixed it in. We would say, did you taste the baby food before you gave it to your baby? And they said, yes. Did you notice any iron taste? And they usually said no. But the one thing they told us was that we had said, we want you to use 1 sachet per day for 2 months. And these are often rural women who are responsible actually for farming. And they said, the one challenge we have is that often we have to go out to the fields, often we have to go to the market, and it was very difficult for us to give one a day for 2 months. And in fact, if we missed 2 or 3 days, we felt so guilty that sometimes we'd actually stop doing it. Is there any way, they said, any other way that we could do this? And I'm not going to tell you about the biochemistry of iron, but iron probably doesn't have to be given every day. So based on these conversations with the mother, we designed the following study that is on this board. One is, in one group of anemic infants, we gave iron on a daily basis for two months. So we gave the mothers 60 sachets, and we said, please use them daily. In the second group, we gave the mothers 60 sachets, and we said, you don't have to use them daily, but over the next 3 months, use them all up. If you want to give every day or every second day, just fine, you decide. And in the third group, we did the same thing. We gave them 60 sachets, and that was our flexible 4-month study. We said, over the next 4 months, we want to use up all the sachets. And the 2 outcome measures for this study were, one, recovery from anemia, and the second was the adherence to this advice. So this study shows that even in the 4-month flexible group, the fact that 72% of the infants were anemic at the beginning, and the number had gone down to 30%, our goal was a 50% decline. You can see that even when the mothers used it, 60 sachets over the 4 months, it worked just as well. This study was very important because now, I'll tell you later, UNICEF is now using this flexible approach, which makes it much easier for mothers around the world. We followed the same group of infants for another 6 months after that 2-month or 3-month or 4-month. What we found is that the rates of anemia continued to go down, and this was really great. And finally, we asked a question about adherence, and you can see the box of 98.2%. So the daily 2-month group, the adherence was, so 88% of the sachets were used for the daily 2-month, 92.7% were used for the flexible 3 months, and virtually all, or 98.2%, were used for the flexible 4 months. So this is a great example of listening to parents in the community, doing a study, and actually having some really exciting results. So the next study we did, we had showed that it was absorbed, we knew the dose, and we knew that it worked in a research setting. So the next question we said, well, it works in a research setting. What about a setting where it's really difficult to deliver? Will parents really use it? And one of the most challenging settings is actually rural Mongolia. So all the pictures you're going to see here are pictures that I took, because you are looking actually at one of the luckiest people in the world. Because through this research, I've probably traveled to 70 different countries, not as a tourist, but as a person who can actually interact with parents and ask parents questions. It was the most amazing experience. And one of the most amazing places I went to was Mongolia. This was, believe it or not, on the very first day I got there, we were driving along. Actually, they don't have roads. We were in a car on the dirt, and I saw this mother holding this child. This is a totally make-up picture. And I thought, oh my God, with this mountains in the background and this beautiful child, I got out of the car and I gave her the package and I said, hold this package, let me take a picture. So this is kind of a fake picture, but it's an absolutely magnificent picture of what a child and the environment looks like in Mongolia. And this is how the rural people live. They live in tents called gers, and they travel with their cattle. And again, there's no roads to these places, but if you want to do a research project to demonstrate that you can distribute the micronutrient powders, the sprinkles, in the most challenging environment, this was it. This is a pretty challenging environment. So, one of the questions we asked is the prevalence of anemia at baseline and final for various age children. And again, I'm not going to spend time with this, but at the beginning of the study, the prevalence of anemia is high. At the end of the study, the prevalence of anemia was significantly lower. So again, what we discovered in Mongolia was there are ways of working with partners in these countries to do the distribution. I should have mentioned that we didn't do the distribution ourselves from Sick Kids. Our partner for the project in Mongolia was World Vision Mongolia. World Vision actually has people from the World Vision organization in countries around the world, and they do a lot of work on improving the nutrition of children. So our partner for this research study is World Vision Mongolia. I could not have gone there without that particular partner. And in every geographic location we work, we only work with partners. These are some of the places we did research, just some of the places, but you can see I had the amazing opportunity to work in many places around the world, and not as a tourist, but actually as a researcher. So I show you this slide again, sorry, the slide of me in the kitchen, to remind you that when we started this process, we only had to make 20,000 sachets. By the end of the research phase, we had to find probably 1 million sachets. And this is the kind of machine that's used to make a package of micronutrient powders. It's a simple machine. You put the powder in the top. The packaging material comes out the side. And this kind of machine can actually make something like 200,000 sachets per hour. So not particularly sophisticated. And there are established production facilities now in India, Canada, Guyana, Indonesia, India, Pakistan, and in fact many other countries around the world. And our aim was to have the technology close to where they're being used. And this is just a picture that I took in Bangladesh of a company called Renata who are making and distributing sachets around the world. And they are now distributing something like 50 million sachets per year. And this is the production line that they have in this company in Bangladesh. So just to remind you that when I went to UNICEF, they had 4 challenges for me. They said, show that it works, show that people will use it, make it in large volume at low cost. It is being made in large volume at a very low cost, and come up with some successful models of distribution. So, the final of these challenges, what I found was in fact the most challenging of all. As a scientist, I could actually do research studies to show that it worked. As a scientist, I could design studies to show that people would use it. I found someone else to make it. The final challenge, developing a sustainable distribution and supply chain, was actually the most complicated one. And of course, as a scientist, not a business person, this is the one I found most challenging. So, sustainable distribution programs must be able to reach and provide sprinkles to the most vulnerable population. Again, our goal here was not to give it to the rich people in India, but to give it to the poor people. And of course, in each country, minerals and vitamins are actually regulated, believe it or not. Sometimes they're regulated as drugs, sometimes they're regulated as a food, and sometimes they're regulated as a different category, but each country has their own regulations. So we actually had to go through each country and get permission to use it through the regulatory organizations. I don't want you to study this slide, but I just want to make the point that when I talk about micronutrient powders or sprinkles, I make the point that the concept is really simple. Babies eat baby food. You have powdered micronutrients in a small sachet, you dump it in the food, and the baby's anemia goes away. What a simple concept. What I found is that taking a simple concept, the full phase from the lab to the village to people, and finally to what I'm calling the value chain, it is not a simple concept. So don't be ever fooled into someone standing up and saying something is really simple. When you want to get distribution to the people around the world, it is absolutely not simple. And this is a great slide to show you some of the components of the supplier value chain to make the point, it is not simple. So, the other thing that's really important, and something I did throughout this project, is finding the right partners. For distribution, there are a number of choices. There's the private sector for production and logistics, very important. UN agencies like the United Nations, the World Food Program, whose responsibility is to provide food in emergencies, and the United Nations High Commission on Refugees, which once again, their mandate is to protect refugees. And I always thought protection was with guns and barbed wire. Protection also means providing food. So the other major partners we found were ministries of health and governments around the world, and large international non-government organizations like World Vision, Save the Children. All of those are particularly important for distribution because the one thing that I couldn't do, and the group at Sick Kids couldn't do, is actually the distribution. Ensuring sustainability perhaps is the most challenging. We had to get private sector involvement, and we did that in Bangladesh, India, and Pakistan. We advocated for national policy and legislation in countries like Guyana, Mongolia, and Bolivia. They actually have legislation to say that an important part of feeding your infant is making sure that they don't have iron deficiency, and the best way to do that is with micronutrient powders. This is legislated. And very importantly is the World Health Organization. So the World Health Organization is the equivalent of our Canadian Ministry of Health. But the difference is the Canadian Ministry of Health is only responsible for Canada. The World Health Organization is responsible in the same way for the world. So they have come up with a recommendation that I'm going to show you in a moment to use powdered minerals and vitamins in both emergencies and in children who need it around the world. So, examples of sprinkles distribution. We tried for private sector for profit, it doesn't work. And the reason it doesn't work is the private sector simply can't make enough because the cost is too low. So we have no examples of private sector distribution. Free distribution using primary health outlets, that is using offices or community health workers, works very well in the developing world. Free distribution via semi-annual health days, subsidized private sector distribution, something called social marketing, distribution with food aid, distribution with unfortified food aid, corn soy blend, and something called conditional cash transfer, which is used in a lot of countries. You give young parents money, like what used to be called in Canada the baby bonus, but it has conditionals associated with it. We'll only give you money if you send your children to school, if you vaccinate them, and if you use micronutrient powders. It's called conditional cash transfer, and it works. So, this is actually really important, maybe the most important thing that I did, and that is that after doing all that research in all these countries in the world, I went to the World Health Organization, and they have a process for this, and I said it's going to be very important if the World Health Organization actually recommends the use of micronutrient powders, because ministries of health will listen to me, but not much, but they will listen to you, WHO. So in 2011, they came up with a recommendation published around the world called the use of multiple micronutrient powders for home fortification of foods consumed by infants, children 6 to 23 years of age. This was particularly important, because with this, now ministries of health are saying, it's not just me saying it, it's the World Health Organization. The UNICEF was one of my major partners for distribution, and this slide simply shows that they're spending every year about $40 million on distribution. And here's how it worked. Remember I talked about going to Copenhagen, very beginning, putting my idea to them challenged me. I went back to New York, which is where the distribution, not the distribution headquarters, but UNICEF is. And every 6 months, throughout this period, I updated them. I said, this is what I've been doing, this is what the research shows. And finally, after doing it for 6 or 7 times, and this is in the early 2000s, about 2010, one of my visits there, at the end of my talk to them, and I said, I've done what you said. You had 4 challenges, and I've done that. It's now your turn. And they said, to my incredible surprise, we are now going to take this on. This is going to be our mandate to distribute it around the world. And you can see that in 2014, they spent $35 million distributing micronutrient powders. In 2011, they distributed it to 20 countries, reaching about 14 million users. In 2014, it was up to 43 countries implementing micronutrient powders, reaching at least 50 million children. I say at least because actually we don't know the number of children. It's in this range. And the last time that UNICEF put out their annual report, they said that they were in 62 countries, and they estimated that they were reaching about 20 million children per year. So, incredible distribution by UNICEF around the world. So when I try and talk about the impact to date, I would say that there have been at least 60 million beneficiary children in 74 countries around the world. There are manufacturing facilities in about 20 countries or more in the world. I should tell you that when this started, I took out a patent for it because I didn't want the large pharmaceutical companies to come while I was doing the research to say that it was theirs. So during the research phase, I had the patent, and I could say who was making it and what the quality was. Once I found that the research was working, I gave up the patent. And what giving up the patent meant, it meant that it could be made by anyone around the world. So when I say that there are about 20 manufacturing facilities around the world, there may be 20, there may be 25 or 18, I don't know, because it's actually out of my hands. I no longer control this, which is good. Lack of control in this case is good. The production is at least 600 million sachets per year, and it's probably closer to 1 billion sachets per year. The distribution models are the public sector model, UN sector, subsidized private sector, and finally, the impact is a 40 to 50% reduction in the prevalence of vitamin and mineral deficiencies, primarily iron deficiency, but not just iron. So for example, in Ghana, we also include vitamin A in the formulation because vitamin A deficiency causing blindness was an important problem. And what we try and do is we try and make sure that the package reflects both the language and the community. This is the package that's being used in Mongolia. It's interesting that Mongolia, like Canada 50 years ago, has a major problem with vitamin D deficiency rickets. And when I was a child, we used to take cod liver oil. The reason we took cod liver oil was because we wanted to prevent rickets, which is vitamin D deficiency. After we were children, after I was a child, Canada put out regulations to put vitamin D in all fluid dairy products, and that's why in Canada we have very little vitamin D deficiency. In Mongolia, the children drink milk, but they drink it directly from the animal. And the animal they use is actually mare milk. I was actually there to milk a mare. I didn't even know what a mare was. But a mare is a female horse. And they drink it right from the horse, and therefore there's no opportunity for fortification. So we actually add vitamin D to the micronutrient powders to prevent vitamin D deficiency rickets in Mongolia. In Bangladesh, where 8 out of children are anemic for iron deficiency, with arrested development, of course, the sprinkles contains the iron, as I've talked about. And finally, in Pakistan, where zinc is actually important for the prevention and treatment of diarrhea, we include zinc in the formulation. So just some examples of the different formulations. So again, as I'm ending, I would say that there's a critical pathway for how I got from the beginning of the story to the end of the story. That is identifying the problem, trying to find a solution, the initial challenges to the problem, scaling up to countries around the world, which continues to be a major challenge, and looking at the barriers to scaling up. And there are a number of barriers that we're still coping with today. So this problem is not over, because there probably are 400 or 500 million children still with iron deficiency left in the world. So this remains an unsolved problem. Of course, I would like to, strongly say that I didn't do this alone. I had both major funding partners and major research partners around the world. It's very interesting, and I hate to say this, but in the very early days, when this was just an idea, where there was no research results, I could not get any Canadian funding. I went to what was then the Medical Research Council of Canada. I went to CETA then, and they said, well, if you have some pilot project that we can look at, we can give you some money. And I said, well, I don't have a pilot project because we don't have a pilot. And it was actually the initial funding was from the United States Agency for International Development, or USAID, which is actually the largest aid agency in the world. Once we had our initial studies done, then it was a lot easier to get Canadian funding, and we had funding from a lot of organizations, both public and private organizations. So I'd like to make the point that this could not be done by me alone without huge funding partners, and of course, partners from the Hospital for Sick Children, partners from my research students. It's interesting that the World Bank has said that probably no other technology available today offers as large an opportunity to improve and accelerate development at such a low cost in such a short time. So of course, it is recognized as being important. And of course, working at this incredible institution, this is the Hospital for Sick Children Research Institute building, built 5 years ago. We just had our anniversary. All the researchers are there now. I went to an amazing medical school, and I now work at an amazing institution. There are 3,000 people doing research on children's diseases at sick kids, and it allowed me the opportunity to pursue my passion, which was to find a solution to this problem. This is a picture of me in Sri Lanka holding a baby, and again, as a pediatric nutritionist, this is as good as it gets.